So the next speaker is going to be Mohammad AIHAZZAZI, who's going to be speaking on surgical management of submacular hemorrhage.
Thank you very much for the introduction. Thank you for the organizers. So this is my talk. I'm going to talk about a general approach of the management of the submacular hemorrhage and my preferred technique as well. I have no disclosure. So why submacular hemorrhage is harmful? We know that the blood in the under the retina cause stripping of the photoreceptors, and this will cause damage mechanically. It causes also toxicity to the photoreceptors by the iron deposit, and also it can cause like a barrier of the RP and neurosensory retina. And it has been shown that in experiments that within 24 hours, the permanent effect on the photoreceptors can occur. The etiologies are numerous. The most common one is the choroidal neovascular membrane, secondary to AMD. There are few factors that are associated with the poor visual acuity even after the treatment, which is the presence of choroidal neovascular membrane, the thickness. There is no consensus about how much thickness is more harmful. However, most of the literature talking about more than 400 microns. AMD etiology and the large area of the hemorrhage. Here, what is important to know that the shorter the radius of the submacular hemorrhage at the center of the fovea has more favorable outcome and the intact of the ellipsoid zone and anterior limiting membrane. There are few things that you need to look in the OCT. There are four things that are very important. The most important one is the level of the submacular hemorrhage. If it's centered in the fovea or it's away. The second thing is the measurement of the thickness. Again, we mentioned that it's around 400 microns. The third thing, which is the reflectivity. So the reflectance will give you indirect way of measuring whether this is really involving the center of the fovea and need to be treated. And the last one is the intact of the ellipsoid zone and the external limiting membrane. In the OCT down, you can see the one on your left, where you can see an elevation. However, if you see the high reflectivity, is only one part of it. The remaining is kind of serous fluid. So this is less harmful to the photoreceptors. However, on the right side, you can see more of hyperreflectivity, which is representing more of clot and more of blood. So what are the treatment options? It can be observation in small hemorrhages under the retina. You can also proceed with only monotherapy of anti-VEGF alone, and you can also use the either pneumatic displacement along with TBA or without. Is there any, what is the preference of anti-VEGF? The anti-VEGF monotherapy has viable option for the treatment of submacular hemorrhage secondary to AMD. Studies has shown that good visual outcome with 44 to 60% of eyes achieving in 3 to 4 months improvement at 6 months. And the eyes with more than 450 micron achieve better outcome if it's combined both therapy. However, monotherapy also has shown to be effective. So is there any preference, any kind of anti-VEGF to be used? There were no evidence supporting any kind of anti-VEGF on top of other. However, it has been shown that aflibercept showed cleaved by the TBA whenever it's combined in vitro, and this will decrease its effectiveness. Pneumatic displacement, it pushes the blood away from the fovea. It can be performed with or without the intravitreal or subretinal TBA. it has been also shown its effect in the displacing the submacular hemorrhage without the use of TBA, for example, completing the displacement in about 80% within 1 week alone. Moreover, it provides also an added benefit of faster visual recovery, and also if you're going to treat the patient with, let's say, laser and need visualization after the use of ICG, this will help you to displace the blood away from the center. It's not any more different than if you are doing pneumatic retinopexy. Those who are familiar with doing pneumatic retinopexy for treatment of retinal detachment, this is just a simple, straightforward technique. So let's talk about the TBA. TBA can be injected in the subretinal space, and this require some preparation. However, it can be injected in the vitreous cavity, and I'm gonna show you that it is less invasive and it has less time consuming, and technically it's not challenging. You are just doing this if you are injecting an anti-VEGF. And some of the studies that confirm that the TBA injection intravitreally can migrate across the vitreous cavity and to the retina under the retinal space. This study looked at comparing if you are injecting the TBA in the vitreous cavity or in the subretinal space, and it has been found that the outcome after 6 weeks post-operatively, 100% of the patient with subretinal TBA compared to 97 if you are injecting this in the vitreous cavity. And this is actually a very nice comparison and very nice results. In terms of vision after 6 months, it showed a similar visual outcome. And those results suggesting that the intravitreal TBA injection may be sufficient to affect dissolution of the submacular hemorrhage and effectively in similar way compared to subretinal TBA. This is another study also comparing the use of subretinal TBA compared to intravitreal TBA, and you can see as a conclusion both treatments showed equal efficacy in displacing the blood. So let's take some of the few examples. This is only a patient with presenting with a hemorrhage secondary to AMD with drop of vision. You can see after 5 months of monthly injection of anti-VEGF alone, the visual acuity improved to 20/30. This is another case with only pneumatic displacement, pushing the blood away from the center. Again, good results. This is a young patient presented with sudden decrease of visual acuity, and you can see in the OCT on the right side, the blood is under the fovea. This is my preferred technique where I inject the intravitreal anti-VEGF along with the TBA in the first session. Then I bring the patient second day with a bubble, and you can see the bubble displacing the blood away, and the patient improve in his visual acuity. This is how the OCT look like at week 1. Then the visual acuity improved to 20/50 on the second week. 1 month later, the same patient presented with the same complaint. However, this time, if you look at the OCT on the right side, now the blood is under the RPE, it's not under the retina, so it's not as harmful as it is in the subretinal space. So the treatment was different. I just injected the patient with anti-VEGF. Then I took the patient for ICG, and I discovered that the patient is showing, you can see it maybe if this is possible, you can see there is a polyp here, which is extrafovea, which was treated only with laser. Patient for the last 2 years, he's doing fine, no more bleeding. This is another 72-year-old male presented with the same complaint, treated with the same way. You can look at the OCT. If you take the cut, which in this location, it's showing blood. However, if you go to the fovea, it's only very minimal blood in the subretinal space. So again, this patient was treated with the same maneuver, intravitreal anti-VEGF with intravitreal TBA. Then the next day, patient is placed back with in face down position after the injection of one. Do I get?
Go ahead.
Yeah.
Keep on going.
Then a gas bubble, which was injected the second day. And the rationale for this, I give, especially in AMD cases, I give a chance for the first day with anti-VEGF and TBA, and ask the patient to be on supine position where the anti-VEGF and TBA will be in contact with the retina. For the next day, patient will be placed with in face down position where the bubble will be pushing the blood away after it has the maximum effect where the TBA already started to work on the first day. So this is 1 week later, you can see the blood is displaced inferiorly. This is the same patient 2 weeks later, his visual acuity improved to 20/60. This is another diabetic patient with, again, submacular hemorrhage, was injected with TBA, and this is the result. Subretinal TBA technique, it's again, it does not require a steep learning curve because you do have actually an elevated retina, so it's easy to be injected. How much you inject, I usually prefer not to inject more than 0.5 ml of TBA to avoid iatrogenic macro hole. Then air fluid exchange and bubble if we are going to do the subretinal TBA. Again, this is the surgery. It shows you how there is already an blip with the blood elevating the retina, so it's somehow safe to go in the subretinal space. It does not require a steep learning curve. How big is the bubble? I always prefer, if you do only the intravitreal TBA, to have a medium-sized bubble, not to have as large as this one, because this will give a chance for the bubble to push the blood away from the center. So again, this is the token message. There is no clear guidelines or special technique to treat the submacular hemorrhage. Maybe the most important is the aerial intervention, which can give a better outcome. Treatment strategy depends on how large is the submacular hemorrhage, the availability of the instrument that you can use for this one, which is the availability of the 41 or 38 gauge cannula and the TBA in the OR, the time of presentation, and your preference to go as office-based, less invasive injection with intravitreal compared to if you go to vitrectomy along with subretinal TBA. Thank you very much.